I think that unlike medical oncology, it's difficult to say what a personal approach in surgery is. But the personal approaches have to do with patients who come that are unusual, or what would you do differently in those patients. Let's say the patient who has a small nodule and the randomized trial's not in yet as to whether you should do a sublobar resection or not, meaning less than a lobectomy. Well, for me, I think it depends upon telling the patient exactly what the pluses and the minuses are, depending upon what their cancer looks like. And so most of the time, in a patient who has a small lesion now, instead of doing a lobectomy, if I think that the patient's going to have a lesion that's going to be amenable to a segmentectomy, I'll do that, because I worry about whether the patient's going to develop a second primary. And I think that these small things that we're picking up incidentally now don't have the same sort of aggressive nature that the large tumors that we had before. The other thing about personalized care is, should you, in patients who have advanced disease, patients who have lymph node disease, should you be operating on those patients? Well, I think that there's a certain cadre of patients that need to be operated on, that you get good local control, that you just don't give chemoradiation therapy to. And in fact, if you look at all of the data, of induction chemoradiation therapy, and then compare that to studies with surgery, as opposed to no surgery, everybody's at 40% 5-year survival. Every single trial like that ends up. So it doesn't really matter as long as you do what's right for the individual patient.